ايوه. الان واضح.
هي الشاشة طالعة بيضة دلوقتي يا دكتور.
ايوه ممتاز. اذا ان شاء الله واضح. وقت ما تحبوا نبدا باذن الله.
ممكن الشاشة اللي فيها العنوان بس بتاع المحاضرة؟
اي هذه هي الشاشه الكريمه. ظهرت الشاشه.
تمام زي الفل كده.
طيب ممتاز.
توكل على الله ونبدأ دكتور كلنا ولا نستنى 3 دقايق كده تكون الناس جمعت؟
مثل ما تحبوا، اذا تحبون نبدا نبدا.
تمام
تمام.
نبدأ إن شاء الله. اتفضل يا دكتور وفاء.
السلام عليكم ورحمة الله وبركاته، ازيكم يا شباب؟ يعني واحنا في ليلة تانية من ليالي الاكسبرت سامتس، ويعني نتشرف النهاردة معانا أستاذ دكتور حسن قحل، استشاري العناية المركزة للأطفال وأستاذ مساعد بكلية الطب بجامعة كازان، والبورد السعودي، والزمالة السعودية في العناية المركزة للأطفال، ورئيس اسم الأطفال بمستشفى الأمير محمد بن ناصر بجازان في المملكة العربية السعودية، وقائد مسار العناية المركزة للأطفال بتجمع جازان الصحي. يعني احنا اتشرفنا بحضرتك، يعني وحضرتك مكسب ان حضرتك تقول لنا محاضرة قيمة زي دي، أستاذ دكتور حسن. ويعني متشرفين جدا ومتشوقين لسماع هذه المحاضرة، وتشرفنا بحضرتك جدا. دكتور حسن المايك مع حضرتك.
شكرا جزيلا دكتور وفاء، شكرا على التقديم. وانا اتشرف حقيقي ان اكون معاكم. و I want to extend my thank for the Egyptian Foundation for Egyptian Pediatrician for me this an opportunity to be here with you and to present such important topic in pediatric and pediatric critical care especially, which is when the pediatric airway fight backs about the advanced management of difficult pediatric airway. I will start my presentation. Bismillah ar-Rahman ar-Rahim. We'll start initially by the objective for this presentation. I will concentrate on what the data tell us about the difficulty of pediatric airway, and to identify understanding the difficult pediatric airway, and also about the management of pediatric difficult airway. And then we'll conclude our presentation stepwise escalation strategy to treat difficult pediatric airway. So I will start by this case scenario, and I think this case scenario it's in all the BICU worldwide and in our institution, who's girl with 6-month-old known case or diagnosed or admitted to BICU as case of severe bronchiolitis. She is 7 kg on high flow nasal cannula. The maximum flow and FI2 is 100. Despite FI2 is 100, her vital sign, the heart rate is 178, and the saturation, despite FI2 is 184, and the blood pressure maintaining with 87/47. So after the maximize the medical management, she's failed to pick up the saturation. So the team decided to intubate her, and then the first intubation was actually failed. And then by during the second intubation, the patient has developed bradycardia and arrest. And I think this is a famous situation or famous scenarios in our institutions all worldwide. And what if this could have been prevented? How we can prevent this data? Let me to ask questions. What kills first in pediatric airway emergencies? Is it hypoxia, hypotension, or delay or overconfidence from the operator or from the intubators. I think all of us, we have the right answers, and we know that's the hypoxia killing first. But to answer this question, we have to collect data, and after we collect data, it will give us an evidence, and then we can translate this evidence to safe clinical practice. So from where we can get data, this is the most famous registries worldwide regarding the pediatric difficult intubation. So maximum of it is coming from the anesthesia, which the first one is the pediatric difficult intubation registry, and then we have anesthesia practice in children, and it was observational trial, and then the nectarine, which is neonate and children audit of anesthesia in Europe. The pediatric register or difficult intubation registry was conducted from 2012 to 15, including more than 10,000 difficult pediatric tracheal intubations, and then the apricot, which is conducted from 2014 to 2015, and including more than 30,000 anesthetic procedures in 30,000 children's, and then the last one which conducted from 16 to 17 or 2016 to 2017, and including more than 600 or 6,500 procedures in more than 5,000 patients. What this data tell us? So what the data tell us about the risk factor of pediatric difficult intubation? Regarding pediatric registry that show the difficult laryngoscopy was around 7.8%, and the difficult intubation in 8.7%, and there is a different definition between the difficult intubation and difficult airway. Also, they found that laryngoscope, it's improved the visualization in 80% and improved rescue in 20 to 25%. And they found the complication difficult airways from 28 to 30%, while severe complication like bradycardia and cardiac arrest develop in 12 to 13% of the patients. And then they found that the craniofacial anomalies, it's a higher risk factor that increasing the risk of failed intubation by 4 times. What about the apricot? Apricot, they found that severe critical event in pediatric airway around 5%, and the most common in the respiratory critical event is what the laryngospasm is 1.5, while the airway obstruction only in 0.4%. And they found that the infant less than 1 year, they at a higher risk for airway event by 2 to 3 times. What about the nectarine? Nectarine, they found that severe preoperative complication is 13.7%, and the airway-related event in 4.7%. That the most common was the hypoxemia, which from 30 to 40%, and bradycardia from 10 to 12%. While they found that prematurity and low birth weight, they are at the highest risk for difficult intubation. So let us back they found that the first attempt succeeds, it's in saving life and saving the airway, and they found that the first attempt succeeds is the strongest predictor of safety. In pediatric registry, they found that complications of pediatric airway increasing from 10% to 30% after second to third attempts, and they found also in apricot that respiratory event increased by 2 times with repeated attempts, and in nectarine they found that hypoxemia and bradycardia spike after the failed the first attempt. So let's back to our patient who's 6 months with 7 kg with severe bronchiolitis and high flow. We try in the first trial, then the second trial, patient developed bradycardia and arrest. How we can prevent this event before we touch the airway? By the evidence that the patient is a higher risk. Why high risk? Because its anatomy actually is not difficult, but physiological instability with hypoxia and tachycardia, it's higher complication risk, and multiple attempts will increase the risk from 10% to 30% for the complication. And by because they found this is patient 6 months old, is less than 1 year old, so the higher risk for difficult intubation and also respiratory events. And also they found by the data that the risk of hypoxemia from 30 to 40%, and risk of bradycardia is 10 to 12%. So how we can optimize this patient before we touch the airway? By all the data that we speak on, we have to start high flow, 12 per kg, and actually the patient already on high flow. It will reduce the saturation from 40 to 50%, and also repositioning the patient with the head elevated, and also we will start fluid and we push dose of epinephrine, and the push dose of epinephrine in case of arrest, it will be ready, and the crash cart also. And then we physiolaryngoscope, it's as a plan A. We'll avoid to try with direct laryngoscope, and also check drug and ETT size, and then we two skilled operators in the room to intubate such patients. So without evidence, this patient has an over-oxygenation, junior intubator, direct laryngoscope use as blindly as a first trial, long apnea, so SpO2 drop to 55%, then patient develop bradycardia and cardiac arrest as what happened in our patient. But with the evidence, we know that with optimized high flow nasal cannula, senior intubator, laryngoscope as plan A, and short apnea time, and SpO2 remaining more than 92%, so stable heart rate, and patient will be stable during the procedures, and will finally intubate safely. So this is how evidence become a practice. Let us talk about how to identify understanding the difficult pediatric airway. There is a difference between a definition of difficult airway and difficult intubation. While difficult airway is an ability to maintain oxygenation and ventilation despite optimal bag mask ventilation, or adjuncts, or like subglottic airway, or supraglottic airway, or tracheal intubation, or surgical airway access, or actually both. While difficult intubation, if we eliminate more than 3 or equal more than or equal to 3 attempts by an experienced provider, or more than 10 minutes without successful tracheal tube placements. So, and about the failed airway or cannot intubate, cannot ventilate scenario is defined as the tracheal intubation and rescue oxygenation ventilation via mask or supraglottic airway have failed, leading to impending hypoxemia requiring an emergency FONA, which front of neck airway, or ECMO. By the pediatric registry, pediatric difficult airway registry, intubation registry, they define the difficult airway when we have a failure to visualize focal cord on direct laryngoscope by an experienced provider, or invisible direct laryngoscope because of abnormal anatomy, or failed direct laryngoscope within the last 6 months, or direct laryngoscope felt to be harmful in a patient with suspected different or difficult laryngoscopy. Why pediatric airway is difficult? This is the most important questions, and we have to know that what's make the pediatric airways difficult. Actually, there's a multiple factor, which can be anatomical, or physiological factor, or some congenital and acquired condition, and some human factor, which usually we ignore it. What about the anatomical factor? As we know, in infant, the occiput is large. So in normal position, for the infant, there is an affliction in the affliction for the neck in the supine positions, and may obstruct the airway. Also, the tongue is relatively large and related to the oral cavity, so easily obstruct airway and complicate laryngoscopy. And also, the epiglottis is long and floppy and omega-shaped epiglottis, so it will be harder to lift during the intubation. And also the larynx is higher and more anterior in children in comparing to adults, so will have a difficult to alignment of the airway access during the intubation. So the airway, it will not be visualized easily. And we have in the narrowest point in the pediatric airway, which is the cricoids, and traditionally is the narrowest point in the pediatric airway. Nowadays, there's some evidence that say the focal or the focal cord is the narrowest, especially in neonates. And the trachea is in pediatrics is short and more compliant, so risk of right mainstem intubation or accidental extubations after the intubation. The chest wall is compliant thoracic in pediatric with horizontal ribs, so it's make the pediatric patient easy to be a fatigue and to develop atelectasis. What about the physiological factor? As we know, the pediatric patient, they have a high oxygen consumption, so the infant consume from 6 to 8 milli per kg per minute, which in double the adult rate. So they are prone to rapid desaturation during apnea, even with pre-oxygenation. And also the pediatric patient, they have low functional residual capacity from 20 to 25 ml per kg in infant, in comparing to adult almost 50%. So, and it increasing with the age, and so clinically it will limit the oxygen reservoir and that lead to rapid desaturation during apnea and hypoventilation or airway manipulations. And also they have an increased CO2 productions. So CO2 production in infant from 10 or 100 to 150 ml per kg per minute. So clinically, the minute ventilation is higher with the a relatively fixed tidal volume 6 to 8 ml per kg. So the infant rely on respiratory rate to maintaining the minute ventilation and to clear the CO2. So, and also they have a rapid saturation. As we mentioned, they have a high oxygen consumptions and they have low functional residual capacity. So the SpO2, it will drop from 90 to 60 in less than 60 seconds of apnea. So this is a short time to manipulate the airway. So clinically, the hypoxemia, it will develop and then leading to cardiac arrest if uncorrected. Also, the cardiovascular response in pediatric and different to adult, the parasympathetic predominance, so the hypoxemia and laryngoscopy trigger bradycardia and hypotension, while in tachycardia in adults. So the infant deteriorate with vagal bradycardia and risk of arrest if hypoxia persists. And also they have an immature respiratory muscle hyperversion of fatigue bone type 2 fiber. So they are relying on respiratory rate to maintain minute ventilation, but it's easy to be a fatigue and they develop atelectasis. Some additional considerations as a physiological factor in pediatric, they are nasal breather, or they have a nasal breathing. So is with nasal obstructions, it will increase the work of breathing markedly, and also the airway reactivity. They have a high laryngospasm risk, and airway caliper with a small edema, they will increase in resistance, and they have also low glucagon stores, so they develop hypoglycemia rapidly. What about congenital condition? As we know that we have in pediatrics some congenital syndrome related to the pediatric airway difficulty, like if including in oral cavity like Robin syndromes, or trachea like Kibble-Field syndromes, or some in mandible and maxillas like Abert syndrome, and also in some acquired condition if the patient has subglottic stenosis or vocal cord paralysis, or some infectious causes like epiglottitis or abscess or tracheitis, or neoplastic causes like papilledema or hemangioma or intestinal masses, or other if patient has a history of prior surgery or radiation or severe obesities. What about the human factor, which most of the institutions, they ignore it and they neglect the human factor, which is the play a major role in pediatric intubation, which can be provider related, like limited pediatric experience, or team related, which poor communication and unclear rules or fixation error, or it's some related to system with missing equipment or incomplete difficult airway carts. Regarding the assessment of pediatric difficult airway, we have some bad outcome contributing factor, which these factors, poor assessment is the first factor that make the pediatric airway is difficult, from anticipated pediatric difficulty to unanticipated difficulty, and this is make the situation as an emergency. So poor assessment, poor planning, and repeated attempts, as we know by the evidence, and failure to use device such as an LMA, or lack of monitoring, or slow response to hypoxia, which can develop rapidly in less than 60 seconds, and at the end failure to plan for failure. So we have to plan if we fail, what we will do. Regarding the assessment of pediatric airway, it's actually multimodal, depending on the history, examination, some syndromes, and demographic, and some scales. Regarding the history, if patient have a history of previous airway difficulty, so if he has a history of failed or difficult intubation, poor mask ventilation, or he has history of trauma like maxillofacial injury or cervical spine injury, or some infectious causes like retropharyngeal or pretensular abscess. And we have, as we know, syndrome and some airway feature related, like in bilirubin, the most famous one is with micrognathia and glostosis. So it will backward the displacement of the tongue, so it will obstruct the airway and make the intubation is difficult. And we have a different syndrome. Regarding the examination, we have some sign during examination that will make the face mask ventilation is difficult, which is like facial tumor or abnormal anatomy. We will have a poor face mask seal, or craniofacial syndrome like bilirubin or others, which will make difficult mask fit. And if the patient has severe obstructive sleep apnea, the airway obstruction during mechanical ventilation, and high desaturation risk. And there's some sign also it will make the intubation difficult, like mandibular hypoplasia or poor mouth opening, or a patient has obstructive sleep apnea or stridor or facial asymmetry syndrome. So it will make the intubation difficult. What about demographic? By the data, we know the patient less than 1 year old, they have a narrow airway, high oxygen consumption, and low reservoir, low functional residual capacity. So they are prone for rapid desaturation and overpresented in registry if the patient weight less than 10 kg, so they are a higher airway complication rate. And also if the patient has a comorbidity like congenital heart disease or obstructive apnea or neuromuscular disorders. What about the scale? Actually, most of the scale is derived from adult, so the sensitivity and specificity inconsistent. So, and many measure laryngoscopy few, so no gold standard pediatric airway scale. We can divide the scale to classical scale, anthropometric scale, or composite pediatric scale. Regarding the classical scale, we have an Cormick-Lehan test, and we have also Malabati test. Cormick-Lehan test is 4 graded, and in grade 3 and grade 4, they have a difficult airway, or they are prone to have difficult airway. In Malabati test, also it's 4 classes, and class 3, class 4, they are a high risk for difficult intubations. And also we have best oropharyngeal view, so no tongue protrusion like an Malabati, so make it more suitable for children less than 5 years, and also to 4 grade from grade 0 to grade 3, while grade 2 and grade 3, they are a high risk to have a difficult intubations. We have also some bedside predictors by the examination, like thyromental distances or sternomental distances, and both is a variable in infant and in pediatric also. And we have also an upper lip pitting test, and we have interincisor distances, and all needed cooperative, so make it variability in pediatric patients. Also, we have anthropometric measurement. Why anthropometric measurement? Because the conventional bedside airway, what was we talk about, is it's a test require patient cooperation and make it limiting used in pediatric, but the anthropometric measurement can be performed at rest, making them useful on non-cooperative infant. So pediatric evidence remain limited. What about the anthropometric measurement? We have a frontal plan to change distances, and we have hyomental distances. The frontal plan to change distances, as in the picture, it assists the retrognathia, is one of predictor of pediatric airway difficulty, and we have hyomental distances which is reflect the mandibular space, show short hyomental distance is associated with higher risk of difficult intubation. Also, we have some air-based measurement, which from the air tract to corner of the mouth, or air tract to the nares, or air loop to corner of the mouth, and all of them can predict the pediatric difficulty before we proceed for intubations. And also, we have composite pediatric scale, which is 2, Colorado Pediatric Airway Score, which COBR, and pediatric airway assessment using Lemon. Pediatric or Colorado Pediatric Airway Scores, or COBR, it's C for chin and the O for opening previous intubation or obstructive sleep apnea, or assessing the uvula and the range of motion of the pediatric airway. And then after we collect the scores, we can know the difficulty of pediatric airway, which started from the 12 to be more difficult and more difficult if we more than 16, so are usually incompatible with life without an artificial airway. What about the pediatric airway assessment using Lemon? Lemon for L for look externally, so you will see the anatomy, evidence of trauma, loose teeth, jaw abnormality or stomach abnormality, and you will evaluate the mouth opening and thyroid cartilage to tip of the chin, which thyromental distances we talk about. And you will use the Malabati also to assess the difficulty to evaluate in kids difficulty of airway intubation, and it's difficult in airway because need cooperations. And also you will assess the obstruction, look for evidence of foreign bodies, pain, inflammation, prior surgery marks, and neck mobility before you touch the patient. What's the limitation of the pediatric airway assessment using by lemons, not validated in children less than 8 years, and reduced reliability due to cooperation issue. Now, how to manage the
دكتور
pediatric
حسن
difficult.
دكتور حسن، قبل ما ننتقل
تفضل يا
بس
دكتور.
لمرحلة أخرى اسمح لي أسأل حضرتك. طب which you prefer، يعني حضرتك قلت لنا tools كتير جدا للأسسمنت of the airway، فعشان إيضاحا للشباب which tool would you prefer at which age يعني؟
So no single predictor in pediatric airway. It's a data. You have to collect data and multimodal. So you will start by a history examination, then at the end scale only, and apart from the assessment is not the assessment all in general. It's apart from the assessment. You start by the history. If patient has history of previous surgery, if he has history of previous or recent infection, if he has an abnormality, symptomatic features, and then you will examine the patient, and after that you also by the risk factor or red flag signs or red flag and a risk factor, like if patient less than 1 year or this patient has history of obstructive sleep apnea, obesity, congenital heart disease, then you will go for scale. Scale is different by the age. The most important, the best oropharyngeal or airway or assessment, because it's no need for the cooperation. If the patient of the pediatric age is larger than five months, you can use what they are using in adult, like lemon or malabati or whatever was you learn to use. But the scales
About our
only a
case.
single predictors.
طب about our case يعني how to assess، احنا حضرتك اديت لنا case how what is the scale you would prefer in our case؟
That I will not prefer any scales. Scales only apart from the assessment. Actually, it's not a full assessment. So our patient, by the history or by the data, this patient is less than 1 year old. Also, if he has an hemodynamic instability or regarding the hypoxia, so this by history, and also the weight. If he has low birth weight or has or an ICU admission or previous surgery or whatever was then you will assess the patient like a malabati is not
So you
useful
mean
in such
عشان
patient.
ده this is a question on the chat. This is a question on the chat because you يعني they want to understand you mean we are going to assess every critically ill patient even before intubation, or even before we are going even before we are anticipating intubation for the airway difficulty?
Yeah, this
correct?
or this data, it will give you a hint. This patient has difficult intubation or low, so it will be anticipated or unanticipated. We're talking here on unanticipated. If you anticipate difficult airway, they have another algorithm, so you will be ready from the start. You will call anesthesia, you will call whatever, you will intubate in OR, or if not an emergency, the NT will be beside you. If you need an trach emergency, this is if anticipated. If unanticipated, this is a different scenario. So you will do all this assessment to anticipate the difficulty of pediatric airway. So if you found this patient will be difficulty or you will face a difficulty during intubation, this will be anticipated. So you'll be ready from the start. Everything will be beside you. If the different subspecialty, different equipment, we will talk about the different equipment we will use during intubations if the patient has anticipated as difficult airway or not. I hope it's clear. We will complete, no problem. We'll answer all the question after we see the algorithm, and we'll see how to manage such patient and which device it's available to treat such patient and in different scenario. So let's back to our presentation regarding the structural algorithm for management of pediatric difficult airway. So first of all, the management of pediatric difficult airway has divided to 3 critical area. First one, difficult mask ventilation, or if the patient has difficult tracheal intubation, or in scenario of cannot intubate, cannot ventilate. So what about difficult mask ventilation? The definition of difficult mask ventilation, if we have unable to maintain adequate oxygenation or ventilation using backmask ventilations. As we mentioned before, we have some clinical signs that give a hint that this patient or those patients, they will have a difficult intubation or difficult mask ventilation, like facial tumor or abnormal anatomy, or if the patient has craniofacial syndrome like bilirubin, or have a history of severe obstructive sleep apnea. And so the first point in mask or difficult mask ventilation is the oxygenation. We use this oxygen to pre-oxygenate and use during the apneic oxygenation, or to reduce desaturation during attempt, whatever was the nasal cannula or simple face mask and rebreather face mask or high flow nasal cannula. So never remove oxygen unless is necessary. And then the essential method for bag mask ventilation. So we're using before intubation as pre-oxygenation, or after failed laryngoscopy intubation, or during apnea or respiratory failure, or as a bridge to definitive or rescue airway, even if it's surgical. So it's most important life-saving airway skill. So we have two technique in bag mask ventilation. We have a one-hand technique and two-hand technique. The two-hand technique is preferred. Why? Because it provides better mask seal and improve tidal volume delivery and reduce airway or air leak during mask ventilation. We have some safety method which appropriate mask size and repositioning early and gentle control ventilation with visible chest rise and monitor SpO2 during bag mask ventilation. If ventilation is ineffective, so stop, re-optimize, and then escalate. We have some common mistake happen during mask ventilation using an adequate size and a mask seal, single hand technique in difficult anatomy, poor head and neck positioning, and excessive ventilation pressure causing gastric insufflation and aspiration risk. So mastery of bag mask ventilation is more important and more critical than mastery of intubation in pediatric airway management. And this is how to position the patient to maintain the access during intubation and make the airway easy during intubation. In infant less than 2 years, we're using shoulder rolls, or as we call them, sniffing positions. In older children more than 2 years, we place on a head rest. So we have some adjuncts using during the bag mask ventilation. We have a difficulty in mask ventilation like oropharyngeal or oropharyngeal airway, which facilitate the relief of upper airway obstruction due to large tongue, but it cannot be used in unconscious patient or unconscious patient. It's used only in unconscious patient. So the proper size, it's most important in oropharyngeal airway, because if the size is too short, will push the tongue backward and aggravate the airway obstruction. And if too long, it will touch the larynx and stimulate the vomit and laryngospasm. And also we have the oropharyngeal airways can be used in or oronasal airway. It can be used in conscious patients. The contraindication if the patient have tendency to bleed or have adenoid hypertrophy or basal skull fractures. How to treat the difficult bag mask ventilation? By the Difficult Airway Society, they have this algorithm to treat. The first of all, give 100% of FI2 of 100% of oxygen and call for help early. This is the point I need everybody to know. We have to call help as early as possible. So optimize the head position. Then consider changing, if you don't have an optimized the bag mask ventilation, to change the circuit, the mask, the connector, to reposition the head by open the airway by chin lift and jaw thrust, and natural head position if less than 2 years in sniffing position or more than two years by head rest. Then you consider, depending on the to go for apnea intubation or apneic intubation by maintaining the oxygen during intubation. So if not, so you will insert the oropharyngeal airway and also call for help early. So assess for sorry, I will make it more on the screen. So to assess for cause of difficult mask intubation, which light anesthesia or laryngospasm, or patient has gastric distension, which usually we forget or we ignore it, the gastric distension, which will make the mask ventilation more difficult. And so insert the NGT or OGT. So and maintain anesthesia and CPAP and deep anesthesia, or as I mentioned, for apneic oxygenation by using the muscle relaxant. Then the second line, insert the supraglottic airway device like an LMA. What about difficult tracheal intubation? The definition of tracheal intubation, as we mentioned before, is if we eliminate more than or equal to 3 attempts by an experienced provider or more than 10 minutes without successful tracheal tube placements. And also we have this sign during the examination that will tell us this patient, he will have and difficult during intubation, like mandibular hypoplasia or poor mouth opening, or patient has a stridor or history of obstructive sleep apnea, or he has an facial asymmetry syndrome. So We have a direct laryngoscopy, which most familiar and limited view and difficult anatomy. We have two type of blade. We have straight blade, which Miller and can be used in neonate and infant, and curved blade, which using in older children. Video blade anticipated difficulty in patient who we anticipate as difficulty. So if we anticipate this patient difficulty, we will prepare the video laryngoscope as early as possible, and always prepare two blade size. And endotracheal tube, as we know, we have two types of endotracheal tube. We have a cuff and cuffless or uncuffed tube. The cuff tube would seal the airway against the oropharyngeal and prevent air leak during positive pressure ventilation. A study show less need for tube exchange in compared to uncuffed tube, which we will have a large air leak, so lead to suboptimal pulmonary mechanics often indicate to exchange to larger size tube, and multiple exchange can lead to airway injuries such as subglottic stenosis. So cuff tube is preferred, and prepare one predicted size and one size is smaller, and confirm with waveform capnography as gold standard to confirm the ATT positioning, FN or no. So Golder rule, tube size never justify repeated attempts. So then we have another other modality to as a laryngoscopy, which glidescope or video laryngoscopy, which camera at the blade tip in direct view on screen. So video laryngoscopy is not a magic. You must practice with stylet and bougie before we use in real patient. Evidence favor video laryngoscope in difficult airway and training settings. So the right tool depend on the patient, operator, and the context of the patient if we anticipate or unanticipated difficult airway. Also, we have some advantage for the video laryngoscope, which improve the airway visualization. No requirement for alignment or of the axis, shared real-time visualizations, and magnified and enhanced view. The disadvantage view may be obscured by the secretion or blood. Warm the blade to prevent fogging, and suction aggressively to maintain visualization. Avoid advancing too close to the cord to prevent difficult tube delivery. We have an bougie useful in poor glottic view and anterior airway. If the airway is more anterior, we will use airway for or bougie for intubation. Avoid forceful advancement, and always oxygenate between the attempt to insert the bougie. And also we have some advanced airway strategy in pediatric difficult airway, which rapidly, if the patient has rapidly progressive and physiological driving, and conventional technique may fail, like the direct laryngoscope or video laryngoscope. Rescue and control strategy, not last minute option. I'm talking about the advanced airway strategy is a rescue and control strategy. So not last minute option. Timely escalation reduce hypoxia, bradycardia, and cardiac arrest. So advanced airway skill turn crisis into controlled situations. Supraglottic airway devices. What the role of supraglottic airway devices? It's provide rapid rescue ventilation, like an LMA, restore the oxygenation when intubation fails, and serve as an bridge to definitive airway management, and integral part of modern difficult airway. What's the indication? Failed tracheal intubation, or patient has an inadequate or impossible bag mask ventilation. So we can use in scenario of difficult bag mask ventilation or scenario of difficult intubations. And also it can be used during if the patient has rapid saturation and planned use in anticipated difficult airway. So if we anticipated, you must have the supraglottic airway device beside the patients. So the pediatric supraglottic airway divided to LMA and the IGL. This is the LMA and this is the IGL. Also, we can use the supraglottic airway to intubate the patient through fiber optic technique. So what's the bridge strategy? Stabilization of oxygenation, time to prepare for advanced airway. We can use, as I mentioned, fiber optic intubation through supraglottic airway, and reduce urgency and cognitive overload for the patients. Also, what the limitation of supraglottic airway? Does not protect against aspiration, limit effectiveness with high airway pressure, not definitive in prolonged airway management, so must not delay escalation when oxygenation is inadequate on the pediatric supraglottic airway. What about the fiber optic airway? What the indication for fiber optic intubations? Anticipate difficult airway. So if we anticipate from early, I will prepare the fiber optic before I touch the airway. So we're using during the anticipated difficult airway. If the patient has craniofacial anomaly, limited mouth opening, or cervical immobility, or patient has an airway tumor or edema, or has a brief surgery for the airway, failed conventional laryngoscope with maintained oxygenations. So what's the technique for fiber optic airway? We can use an awake fiber optic intubation, which I not prepared, but some of our colleagues in anesthesia, they are using this technique, which awake fiber optic intubation, especially if the patient is anticipated as difficult airway, or we can be used with sedation, sedated spontaneous ventilation technique, or fiber optic intubation, as we mentioned, via supraglottic airway as a bridge technique. So what the advantage of fiber optic airway for fiber optic technique? So maintain oxygenation and airway reflexes, minimize the cervical spine movement, and allow control stepwise tube placement and reduce repeated traumatic attempts. What the limitation? Require expertise and training. So few easily obscured by discretion or blood, and time consuming in rapidly saturation patient, not suitable for emergent hypoxia. And this is the algorithm show us how we treat our unanticipated difficult tracheal intubations. So if, as I mentioned, in difficult mask ventilation, we have to call for help early. So direct laryngoscope, not more than 4 attempts. Always minimize the attempts for the operators on, and in general for the different operator, we have to minimize the attempts. So in this algorithm, they minimize more less than four attempts. So check neck flexions. Sorry, I will make it larger. So neck flexion and head extension and laryngoscopy technique. So if the patient has external laryngeal manipulation, remove or adjust, sorry, and focal cord open and immobile. So adequate paralysis. If poor few, consider bougie, straight blade laryngoscopy, and smaller ETT. So if we succeed, so we will confirm the ETT positions. If not, the failed intubation with good oxygenation, secondary tracheal intubation plan. So call for help early, insert supraglottic airway device like an MA, not more than 3 attempts, oxygenate and ventilate between every attempt, and consider increased size of supraglottic airway LMA once if ventilation inadequate. If you succeed, so we will intubate, then we make sure about the ATT. If failed oxygenation and SpO2 less than 90, modify to 200, so compared to face mask ventilation, optimize his position, oxygenate and ventilate, then ventilate, use two-person technique as we mentioned, and also manage gastric distension with NGT or OGT tube, and repairs non-depressing relaxant if the patient is electively. This is because the anesthesia driving algorithm. If we succeed, so with postponed surgery, this is because the anesthesia. If not, then we'll go for an emergency airway. So in scenario of cannot intubate, cannot ventilate, which tracheal intubation and rescue oxygen ventilation have failed, leading to impending hypoxia, required emergency aphonia or ECMO. So immediate properties. So call for help, continue attempt to oxygenate, and prepare for emergency airway. So what's the emergency airway? In pediatric, it's rare, but life-saving. Reserved for cannot intubate, cannot oxygenate, or cannot ventilate scenario, and delay is associated with the catastrophic hypoxic injury. What's the indication for the surgical airway or an emergency airway? Is failure for intubation, or failure to bag mask ventilation, or supraglottic airway ventilation, severe upper airway obstruction, or rapidly deteriorating oxygenation despite maximal efforts. So type of surgical airway, we have needle cricothyrotomy or surgical tracheostomy. Surgical tracheostomy is done by our colleague in ENT, while needle thyrotomy can done bedside and by the ICU team. How we can do the needle cricothyrotomy? The pediatric cricothyroid thyroid anatomy is small and challenging, so it needs expertise or requires an expertise. How we can do this video is can show us how the needle cricothyrotomy done bedside for the patient who need an emergency airway or emergency. how we can treat the scenario of cannot intubate, cannot ventilate, or in pediatric patients. So if failed intubation, inadequate ventilation, so give 100 oxygen and corporal help as mentioned. So continue to attempt oxygenation and ventilations by optimize the position, open the airway, and check the seal and the mask size. Then attempt to wake up if the maintaining SpO2 more than 80%. If recuronium or acronium use, consider other element. This is because it's coming from the anesthesia side. So prepare for rescue technique in case child deteriorated. So airway rescue technique for cannot intubate, cannot ventilate, SpO2 less than 80% and failing, and or heart rate decreasing. If ENT available, so you will go for tracheostomy. If ENT not available, you will go for needle cricothyrotomy. Let me to show you. This is an algorithm is developed by our colleague in the Gulf Pediatric Critical Care Society, and in first pediatric difficult airway workshop was done in Kuwait. I like this algorithm because it's make the airway by the different level or different color. They start by the three zones algorithm: the yellow zone and green zone and red zone. The yellow zone for optimizing the position for effective bag mask ventilation and using of oropharyngeal or nasopharyngeal or consider supraglottic airway before you proceed for laryngoscopy or for attempt. So you will optimize the patient. If you optimize, then you will move for the second zone, which the green zone with the pharyngoscope or direct and pharyngoscope. The maximum attempt is 4 attempts, and in anticipated difficult airway, pharyngoscope is the first choice, and consider change of operator, consider change of blade, straight, curved, or consider and bougie and smaller ATT, or you can use a different technique like fiber optic intubation or administer apneic oxygenation via nasal cannula or high flow nasal cannula, treat laryngeal spasm, and if in doubt, take it out. This, if you in doubt and take it out, so you insert ATT and you in doubt this ATT is in or out, and the oxygen is not picking up, so make it's out and just remove it. Call for help if not arrive. Then you, in the scenario of cannot intubate, cannot ventilate, you will go for the red zone, which cannot intubate, cannot ventilate scenario. So if ENT available, we will consider the tracheostomy. If ENT not available, you will consider the needle cricothyrotomy. So this is the conclusion of the presentations. Is an clinical stepwise escalation strategy. In the first step is anticipation, as we mentioned. Identify predictor of difficult airway early. Assume difficulty in any red flag is if any red flag is present, and call for help early. And always put on a plan, not or strategy, not only a single plan. So you must have a plan A, plan B, plan C, or D before intervention for the airway. If you anticipate this patient, it will has a difficult airway. The step 2, the oxygenation step with the pre-oxygenation with different oxygen device and apneic oxygen during attempt. Optimize positioning and SpO2 is the primary endpoint. Then we two-step of ventilate. 2-hand bag mask ventilation is the preferred technique, and use oral airway early, gentle controlled ventilation, and confirm effective chest rise. Then we have the first attempt steps, and is the most important attempt. As we know by the data, it's increased the risk after the failed first attempt. So the best operator, best device, and early pharyngoscopy for anticipated difficulty. Limit attempts, not more than 3 to 4 attempts, and maintain oxygenation between attempts. Then we have to device escalation, change device, technique, or operator. Avoid repeating the same failed approach. Use adjuncts like Bouchon stylate, re-oxygenate before each attempt. Then you will go to rescue the airway, insert supraglottic airway to rescue ventilation, restore oxygenation immediately. Use as bridge to definitive airway. In the advanced airway steps, you will use fiber optic intubation, planned or control intubation through supraglottic airway by using fiber optic intubation, stabilize physiologic before proceeding. Then you will go for surgical airway. In the scenario of cannot intubate, cannot ventilate, immediate activation of surgical airway pathway and time critical action. And then we will go for the team. We must have a clear role assignment for the team who are attending the intubation, verbalize attempt and time, 1 leader and 1 plan. And then you reassess if after you pass the airway by confirm oxygenation and tube positioning, monitor for complication and debrief and documents. So the final take home steps is the goal. Final take home message: escalate early, oxygenate first, and change strategy fast. This is the end, and thank you for your attendees and your listening. Any questions?
Thanks a lot, Dr. Hassan. يعني lecture, very very important lecture because it faces us all. Cannot ventilate, cannot intubate scenario. أي حد من الشباب عنده أي أسئلة؟ هو كان في سؤال اللي هو how many attempts should the vegetation، بس هو باين بعد كده في الليكتشر يعني up to 4 times، صح؟ how many attempts؟
Yeah,
Yeah.
most of the algorithm they minimize the attempted or maximize the attempt from 3 to 4 times for direct and video laryngoscope. But the message always is escalate early as if you found and difficulty in the breast attempt, so go for help early and be prepared. If you are prepared, I think nothing will happen for the patients.
اوكي، حد تاني عنده أي أسئلة يا شباب؟
لو حد يا شباب حابب يفتح المايك، استاذنكم يرفع ايده بس ونفتح له المايك. وشكرا جزيلا دكتور حسن، محاضرة جميلة جدا، تسلم ايدك والله.
شكرا يا دكتور احمد، شكرا، الله يعطيكم العافيه، وشكرا على الاستضافه، واتمنى انه استفدنا جميعا. واذا message maybe the airway it's need a training, so it's an actually need the physician or the clinician to have a practice on the airway in different situation, different by in a workshop many kinds, and in really patients then
انتظرك في مصر بقى ان شاء الله.
باذن الله باذن الله.
لازم
هو
اشرف ايه احجزي.
اللاست انا دكتور حسن انا بعتله من بدري هو معانا ان شاء الله.
ان
هو
شاء الله
معانا،
باذن الله.
هو
يشرفني
ما اتأخرش
جدا،
خالص.
شرفني جدا اكون معكم باذن الله، وباذن الله نتقابل قريب على خير باذن الله، ويكون في شيء ان شاء الله فيه خير للناس وللمرضى وللكلينيشنز ولنا كلنا باذن الله.
امين يا رب.
هو ذا لاست 2 سلايدز هم دول فعلا، يعني الالجوريثم ده لازم يتعلق بقى في كل رعايه، بحيث ان هو برضو يبقى جايد لينا during intubation الستبس ناخدها. يعني اللاست 2 سلايدز فعلا مارفلس دكتور حسن يعني.
I think most of this institution, yeah, they must have all the institutions they must have an algorithm, or they have a difficult airway pathway. So when to call, who will call, what's device we have. We have a difficult intubation cards in the units, or to avoid all this يعني mistakes during intubations. Because most of the difficult pediatric airway is unanticipated. If we anticipate, this is an easy. So you will call for help for senior. You will call early for help. You will call early the surgery, then anesthesia, whatever. The problem when we have a patient with unanticipated difficult airway, and this is the most important.
Yes. شكرا جدا دكتور حسن، شكرا جدا جدا.
في مايك مفتوح برضو لو حابين تجاوبوا، افتح بس المايك، او لو عاوز تسأل سوري الدكتور حسن، والمايك اوتوماتيك هيفتح معاك. لو في اي استفسار، حتى لو انت شايف الاستفسار بسيط، تسأل ما تتكسفش. في اي سؤال؟ طيب
انا ممكن اسال الشباب اسئله؟ ممكن مين كام واحد قابله ان هو حاله difficult intubated difficult to ventilate وما عرفش يتصرف، او الحاله ضاعت، او اضطر يلجأ للتخدير علشان intubate البيشنت، وكان ايه الكونديشن بتاعت البيشنت في الوقت ده؟ لو حد قابله حاله زي كده يا ريت يعني يقول لنا، يفتح المايك ويقول لنا his own experience، عشان برضو نشوف الدنيا كانت المفروض تمشي ازاي يعني.
جميل. حد
I think
يجاوب؟
most of us they are facing who is in work in pediatric department or in pediatric ICU. They have they're facing an scenario of difficult intubations.
هي موست كيس بتهيألي ديفيكلت اللي هي بتقابل في النيونيتس بالذات، اللي هو البيير روبن، الانتوبيشن بتاعها
Yes.
بيبقى very 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 difficult يعني. even the anesthesia بيبقى missed منهم. فهي
Yes.
دي one of the
Yes.
most difficult cases اللي قابلتني بصراحة في
Agree.
في شغلي.
Agree 100%. And I think all the unit they have a patient with bilirubin and they found difficulty before they touch the airway. And because if you know this patient has bilirubin sequences, it will be anticipated like difficulty. So you will be prepared. You will call for help early, and even anesthesia they will attend. And even anesthesia sometimes they're refusing to intubate in the unit, then take patient to OR because they have a good facilities there.
حد تاني عنده حالة يا شباب قابلته؟ في دكتورة ايه بتسأل. افتحي المايك يا دكتورة ايه واسألي بدل ما اقرا سؤالك. افتح لك المايك.
هو مفتوح بس ممكن تكون هي مش عاوزة تفتحه يعني. ممكن تقري رسالة دكتور وفاء، اتفضل.
طيب هي بتقول اذا كانت الحالة ARDS ولما بتحط على باك جراوند ماسك بتنزل يعني بالديسات وارستد during intubation، ايه المفروض البروسيجر اللي كان يتعمل يعني، او حضرتك تنصحها بايه الستبس اللي كانت المفروض تتعمل؟
Yeah, this is the same as our patient. This patient has an hemodynamic instability. If the patient he has ARDS, so it will be difficult about mask ventilation. And if the patient has an hemodynamic instability, so you have to optimize before you proceed with intubation. So you try to, if the patient has hypoxia, so two technique or two hand technique the intubation, the most expert one he will be the intubator as an rapid sequence intubation. So you will give the patient a fluid. You will prepare the if the patient is the blood pressure on the lower side, so you will start an inotropic support, or you will sedate well before you, and you will use the apneic intubation technique. So you will use the muscle relaxant and try to intubate this patient as early as possible, not to manipulate the airway for longer time.
هو يا دكتور حسن اعتقد هي تقصد ان sometimes كده بيبقى العيان بالذات لو عنده ARDS او severe pulmonary edema up to pulmonary hemorrhage even لما بنعمل باك اند ماسك ما بنوصلش للبيب العالي اللي هو ينفليت اللونجز. فهي
Yeah, yeah.
فبنحس ان saturation of the patient ما بيرفعش مهما عملنا، حتى لو عملنا effective باك اند ماسكينج، غير لما بانتوبيت البيشنت يعني. فايه رأي حضرتك
Agree.
في condition دي؟
Yeah,
مم.
agree. So you will use the most important point. So we will make the patient like a red flag because this patient has an hemodynamic instabilities and has also an difficulty for bag mask ventilation. So as the algorithm mentioned, so you will call help early. You will anticipate this as patient has an difficult airway because it's hemodynamic unstable. So you optimize all the instability. How to optimize? So you will sedate well. You will use muscle relaxants. You will use a good mask size and mask seal by hand technique. You will prepare the supraglottic device like LMA or IGL or whatever, fiber optics. You will be prepared because this patient has an instability in the oxygenation or has hemodynamic instabilities. And you will prepare also the difficult intubation cards. You try to maximize the patient before you proceed for bag mask ventilation. How to maximize? So you will use the oxygen with 100% to pre-oxygenate, and you will go for the apneic
Yes.
oxygenation also by high flow or whatever we are using before even you bag mask. You will not remove the oxygens. You will improve the blood pressure or hemodynamic status. You will call for help early. It must be the most expert. If we assume this patient will have
Yes.
difficulty during bag mask ventilation, you will ask the most senior who will intubate, who will be ready for intubation. You will be referred during endoscope, fiber optic, whatever. You will use 100% oxygen.
So here we are going to have rapid sequence intubation,
Yes.
and also I want to stress on this is ventilation perfusion. We must برضو إن احنا to improve the perfusion like you said Dr. Hassan by raising inotropes if the patient is in need for inotropes.
So you have to
Uh,
optimize the patient before you proceed for bag mask ventilation or other. How
yeah.
to optimize? By using you have a good hemodynamic status, by
Yeah.
preparing for the scenario of difficult bag mask ventilation or difficult intubation. Your call for help early. You will use an 100% FI2. You will prepare your sedations, your difficult intubation cart. You will use a muscle relaxant to intubate this patient as rapid sequence intubations.
دكتور حسن معلش، الجماهير بتطلب باخر تو الجوريزمز اللي هو الجولف بالجوريزم، واللي بعديه معلش الستيب وايز ابروتش، ان هم عايزينه يبقى عندهم، فممكن لو حضرتك تبعتهم لنا از ايمج
ما
كده
في مشكلة،
اخر.
ولا يهمك ولا يهمك، بإذن الله.
في حد تاني بيسأل، معلش انا اسفه طولنا على حضرتك
لا
دكتور حسن.
جدا أبدا، بالعكس سعيد ومبسوط.
should I give adrenaline shots or infusion in this case؟ هي
which case?
تقصدي الكيس الأولانية يا دكتورة آية ولا أنو كيس؟
ARDS patient depend on your blood
in
pressure and
ARDS
hemodynamic
patient.
status. Yeah, in ARDS
ARDS
depend
patient.
on your hemodynamic status. If patient is in hypotensive or he need an entrop, you have to start entrops. Even some expertise in case of ARDS or asthma patient, they starting entrop with small dose just to keep the entrobes on during the intubation or during the procedure, because if we need, I will escalate early. I will not ask. So it will be ready. You will start at like small dose like 0.01 or 0.03, just to keep the blood pressure maintaining. And if I need to escalate, it will escalate early.
برضه يا دكتور حسن معلش، انا في ابروتش كده بيتعمل ساعات ما بيبقى انتسبيتنج ان هيحصل رينج الاديمه او كده، بيدوا رسامك انبنفرين نبلايزيشن بيفور الانتوبيشن. What's your opinion about that؟
Yeah, it's no problem. If you anticipate this patient, he has an laryngeal edema or whatever, so you will find difficulties during intubation because the patient has a sign of upper airway obstruction. This upper airway obstruction due to edema, I will maximize before I will proceed for bag mask ventilation and intubation. I will give racemic epinephrine or I will give dexamethasone to improve the laryngeal edema. Then I will proceed for intubation. So any steps you will do it to maximize the intubation before you touch the airway or you proceed with the sedation and muscle relaxant, and it will make the scenario worse, you will use. If I need to maximize the hemodynamic by using an adrenaline, whatever. If I need a nebulization to improve the airway edema or dexamethasone to improve the airway edema. If I need a fluid to maintain the intravascular volume is good. Whatever our intravascular volume maintaining before I touch the airway, I have to do it before, because it will be step before you manipulate. If you manipulate, you cannot predict for how long this patient he will maintain the oxygen and hemodynamic status.
Also, Dr. Hassan, about you told us the video, برضو you could share with us برضو الفيديو of doing urgent cricothyroidectomy. Who is responsible
Yes, sure.
medico-legally for this? Is it
No,
okay
I
for
think
the intensivist?
yes. Yeah. I think for intensivist they are illegal to do it. They have an
طب could you
doing
please,
the
Dr. Hassan, share us the
cricothyroiditis.
video? It's very يعني informative و
Sure,
simple.
دكتور. Sure.
شكرا لحضرتك جدا جدا.
عفوا، الله
سهرنا
يحفظك.
حضرتك
شكرا
وتعبنا
دكتور.
حضرتك، ويعني انا ممكن
لا
افضل اسال
بالعكس
حضرتك
سعيد،
ودiscuss لحد
بالعكس
الصبح، بس يعني
سعيد
شكرا
ومبسوط
شكرا
بتواجدي معاكم. شكرا على دعوتكم، شكرا
شكرا
لكل الزملاء، وان شاء الله
شكرا
باذن الله نتقابل في محافل قادمه ان شاء الله باذن الله.
شكرا لحضرتك، شكرا جدا، شكرا
شكرا.
دكتور حسن. السلام عليكم.
شكرا.
شكرا دكتور هلال جدا جدا. شكرا دكتور امير، يعني شكرا لمنصتكم الكريمه.